wrong. So what is the cause between alcohol-induced hypoglycemia? Ethanol, it is actually metabolized to acetic acid through acetaldehyde, and NAD is utilized in this process. NAD is converted to NADH, and this NAD depletion, this NAD is also needed for gluconeogenesis. So, but glycogenolysis is affected in them. So, if the nutrition is not that, if there is enough glycogen, then there is no hypoglycemia to that extent. But if the glycogen store is not that high, if the patient's blood sugar level depends on gluconeogenesis mostly, then this NAD depletion will cause impaired gluconeogenesis, and there may be hypoglycemia, alcohol-induced hypoglycemia. So she is a nursing staff, 45-year-old nursing staff. Duration of diabetes 10 years on metformin, glimepiride, pioglitazone, multiple drugs, including atorvastatin, aspirin, and she was a little bit depressed patient. Acetylcholine was including, and there was uncontrolled diabetes. Ketamine was added, 10 units. Blood sugar control for 3 months. 4th month onwards, there was recurrent early morning hypoglycemia. Then glimepiride and ketamine dose reduced, but there was persistent hypoglycemia. What happened to this patient? She was a nursing staff. She was depressed. So sometimes, and when this occurs in the 4th month, at that time she was on night duty. So she actually altered. This is a real case I have seen. She altered the dose of insulin so that there may be hypo or hyperglycemia. And so the psychiatric patients, they need this patient monitoring. His last 3 or 4 cases, I will take only 2 or 3 minutes for them. These are very interesting. You can see here a 55-year-old male on premixed insulin with his SMBG records. So well-controlled diabetes, but HbA1c 12%. What's the cause behind it? People will say that the HbA1c will not standardized. There may be the lab error may be present, or something, etc. Or he may have comorbidities which may alter the HbA1c level. But the actual thing is that if you follow the SMBG level, that he is yes.
That is an intelligent person, so the day of investigation before night, he was controlling the food diet.
Actually, this is also a real case. Actually, what happened to this patient, you can see here, even at 3 AM, he is taking so many readings. So everything is fabricated. He never takes his reading. So that is the actual problem with the patient. So false records may confuse the doctor. So this is another. The patient is on metformin and saxagliptin, and HbA1c is 11%. Here also, you can see that the records are not that bad, but HbA1c is still 11%. The same thing happened to him also. Selective amnesia, I have told it, because the patient forgets to record this one. When he uses heavy diet, or he always blames himself for his heavy diet. So when there is rise in blood sugar level, he doesn't record it. When there is good control, then he actually records. And this last two, these happen to GDM patients, gestational diabetes mellitus patient. We provided glucometer. Actually, I ran to the company to give a glucometer to the patient, and after 15 days he came with discharge. Only the code number. So these things can also happen. This is just because you all are hungry, so just for fun. The code number sometimes recorded. I have seen one case, and the second case is more beautiful. This is the calibration before reading from meter. All the readings are 888. The reading before calibration. So these things may also happen. So always, although there are so many guidelines, so many paths, but always we should depend on our clinical acumen, clinical judgment, and on the basis of that will lead to the path. So thank you for patient.